The doctor will see you now. The psychology of the doctor-patient relationship. Hello and welcome to the channel. I have made a handful of videos on this channel where I put the spotlight on the psychology of others in various contexts. For example, the psychology of the birth order of European royals. Now, I shine the spotlight on my own profession, or rather, on the interaction between doctors and their clients in the professional setting, as seen through my eyes and the eyes of friends and colleagues. Tit for tat. I would like to share with you a broad overview of what I notice about the doctor-patient relationship. So help me God. May I start with the doctor's own psychology? To sum up the psychology on this side of the equation, I recount the trepidations of good friends of mine and the profound sense of imposter syndrome they battle against every day. Now, just a little context. This sense of imposter syndrome starts the day they release you from the gates of medical school and let you loose on the general population. And it stops the day you hang up your stethoscope for the last time and wave goodbye to your last patient. There are, however, peaks and troughs, depending on your experiences throughout your training and practice. One friend on the verge of becoming a consultant and attending in the US, he was so stage struck that he started having anxiety attacks. And he was one of the most self-confident people I know. He was far ahead of me on the totem pole of medicine, and I looked up to him. So I was shocked to see his reaction to the end of his postgraduate training and the beginning of his role as a fully independent doctor. He was terrified. Suddenly, the weight of that responsibility was almost too much to bear. And this was someone who had had no such fear when he first stepped onto a ward as a newly qualified doctor on his first day as a doctor. In contrast, I was petrified on my first day as a doctor. As Donald Rumsfeld once famously declared, there are known knowns, unknown knowns, known unknowns, and unknown unknowns.
Reports that say that something hasn't happened are always interesting to me because, as we know, there are known knowns. There are things we know we know. We also know there are known unknowns. That is to say, we know there are some things we do not know. But there are also unknown unknowns, the ones we don't know we don't know.
I was distinctly aware that my known unknowns and my unknown unknowns far outweighed my known knowns and my unknown knowns. In contrast to my friend, I transitioned quite well into my role as fully independent doctor at the end of my training. I suspect the reason for this is by the time I completed my own training, I had gone through so many changes that I didn't notice the bigger change. I suspect the reason for this is by the time I completed my own training, I had gone through so many changes that I didn't notice the biggest change of all, the step up into independent doctor status. I had had a change of country, change of languages, change of specialty within medicine, change of style of medicine, change of life in general. But I digress. The exact words my friend said to me in the context of his imposter syndrome was, "So, they want an idiot like me to lead a team?" He looked a bit green around the gills as he said that. This man is now one of the top consultants in his specialty in the world. Imposter syndrome is a hidden blessing. It helps you to either sink or swim. thinking is not an option, so you swim. I remember some hairy episodes in my own experience growing up in inverted commas in medicine. One particular episode that is etched in my memory forever was when I was called to the emergency room for the umpteenth time on my on-call night shift in an island hospital to a man who had just been brought in by ambulance with a heart rate that was regularly falling below 30 beats a minute. As you all know, unless you are an Olympic athlete, a heart rate of 50 to 90 is the norm. It was around 2 o'clock in the morning, and I had been working continuously for around 9 hours at this point. I was hungry and tired and badly needed some sleep. I knew I had to insert a temporary pacemaker in his heart, and fast. He was also terrified at the prospect of having a pacemaker inserted in his heart in the middle of the night. So was I. I was having major imposter syndrome. To make matters worse, I was rather young looking at the time. He expressed concern that I looked too young and made a quip about the NHS letting loose 12-year-olds into hospitals. I assured him I was not 12, making sure to keep a straight face. Next, he asked me if I knew what I was doing. I knew I had to get his cooperation because his life depended on it. I didn't have time to argue with this patient. My bleep was going off every 5 minutes for other patients that needed me. I wasn't sure if I didn't put a pacemaker in this guy overnight, if he'd be there in the morning when my consultant arrived. I decided to try something new, sink or swim. When he asked me if I had ever done a pacemaker insertion before, I decided to turn rogue, to the horror of the nurse working with me, who, by the way, reported me to my boss the next morning. I said to the patient, "No, I have never put in a pacemaker before, but I have read up about it. I have read a book about pacemakers. The first step in every journey is the most important one." He looked at me suspiciously, completely unimpressed, and obviously trying to make up his mind if he would let me touch him. Then I added, "I haven't finished reading the book, by the way." He suddenly laughed, completely spontaneously. I knew I was in. Sweating through the procedure, I got it done in quick time. And later, when he was having his cup of tea and biscuits, now able to breathe and talk properly, he said to me rather dryly, "Doc, I think you clearly did finish that book." It was a surreal and funny moment in my journey as a young doctor in training. For the rest of his hospital stay, he would always ask for me. But I did get the pep talk about not terrorizing already compromised patients with threats of my incompetence, especially at night when the choice of doctor for the patient is low. This is fair play. It was correct to discipline me. I accepted my reproach and told my consultant that I had learned a lesson from that experience. This was indeed true. I had learned something valuable that night, which has helped me ever since. I reckon with my ill-placed joke that I actually broke the ice with that patient. He was skeptical, perhaps also a little bit cynical, but he wasn't sure if he could trust me at all to sort out his emergency heart problem. Now, this is a legitimate fear. No one can blame that patient. He was a Victor Meldrew type from the old British comedy series One Foot in the Grave.
Good for a laugh, just ask its wife. Don't believe it! Always irritable all day long. What's it got to do with you? Hello? Oh, God. What do you think I am, some sort of village idiot? Hello! It's the last time I go out photographing badgers. What the hell's it got to do with you? Oh, for God's sake, go home! Get out of my house! Get out!
Is he always like this?
What did you say to her? I'll bloody well tear your liver out and give it to the cat, you see if I don't!
He either liked you or hated you. Despite his declining heart function, his sense of humor type was coming through loud and clear to me. I read it as dry, deadpan, and rather slapstick. Old school British. I was used to that type of humor. I didn't have time for him to hate me. I had to think on my feet and use his own psychology against him in order to help him fast. I couldn't tell him that I had done hundreds of pacemakers at that point and have him believe me immediately. Sometimes life just doesn't work like that. Patient confidence in a new-to-them doctor is rarely immediate. I had to display my confidence to him almost peacock style in a way that he could grasp quickly to gain his attention and trust. I figured the best way was to be brazenly comical, however inappropriate. Thankfully, I read him right. Another patient and my strategy could have gone horribly wrong, especially if the procedure itself had gone wrong too. Can you imagine that? The point I am getting at is, starting that night, I started to read, in inverted commas, patients in my first interaction with them in order to understand how best to communicate with them in the outpatient setting, and especially in the context of general practice, where I built a relationship with patients over several years. This is becoming an art that I am perfecting with time. I still get things wrong from time to time, but I think I am mostly winning. And I also understand that patients are similarly reading me and have their own strategy when it comes to their interaction with me. Over the years, I have categorized archetypal patient behaviors when it comes to consultation styles. There are archetypes that I relish and others that I am not so comfortable with. But to be honest, it doesn't matter. The important thing is to identify the archetype so that I can adjust my own behavior, my comportment, with respect to the patient. I think that's what's important. A little context here. I am of the type who believes that the doctor and patient are partners, collaborators in the health journey of the patient. This attitude does sometimes get me into trouble, cause the excuse, but the patient said, doesn't cut it. So the middle ground where the patient is seen as a partner in their own health journey, but at the same time, the doctor takes responsibility for the care of the patient, is a delicate balance, but is possible for the most part. So, what are the archetypes I come across in my daily work? I describe them here. No judgment involved. It is what it is. If you are a doctor, does this ring true to you? If you are a patient, and let's face it, we all are, do you recognize yourself in any of these interaction styles that I am about to describe? Spoiler alert. The first one is my favorite one. I call this group the engineers because I find that a high percentage of these patients are actually engineers. This is true, which, as you will see, makes sense. This group of patients come to the consultation on time. They are never late. And they come well prepared. Very often, they come with a list of requests or questions neatly written up on a piece of paper or on an electronic device. Some have even been known to come with a recording device to record the consultation and listen to it afterwards. All done having sought my permission, of course, so no infringement of copyright on their part. The engineer archetype is very organized, highly intelligent. They are very well read on general topics, but especially on their own health problem. They often come with their own differential diagnosis and simply ask me my opinion rather than consult with me. They are true partners in their health journey because they take responsibility for their health. They validate my standpoint that they are at the center of their health journey, and I, as their doctor, am more of an interested bystander than dictator. They seek advice and never accept what you tell them without fact-checking you. They are a very logical group and exceedingly autonomous. I occasionally butt heads with them when they insist on deviating from the path of good, healthy habits. But they are at least kind enough to acknowledge that I am scolding them in their own best interest. A subset of the engineer group, or perhaps this is a distinct group, you decide for yourself, is what I call the specialist. The specialist is the patient who has a chronic illness, often congenital, they're born with it, or arising in childhood, that they have to live with their whole life. One example of such an illness is discussed in this video here. The specialist has their own sink or swim moment in their life and decides to swim. They embark on a journey to learn everything there is to know about their particular illness, to the extent that they know far more about their ailment than their doctor will ever know. The specialist is meticulous and studious. The young specialist will more often than not get into a medical or medical-related profession. It is such a pleasure to watch the young specialist grow and mature, overcome their challenge in life, and emerge an absolute winner. They, like the engineer, are cooperative, seek the best health for themselves, and take care of their bodies. They can set their minds to anything and win. Their parents report that they exhibit leadership qualities early on in life, as they transmute their battle cry against their nemesis, their disease, into a positive force in everyday life. You can't help but root for them. The friend archetype is the patient who wants a deeper relationship with the doctor from the get-go. Now, in the general practice setting, this happens organically with time anyway, depending on how often the patient comes into contact with the doctor. This can also happen with specialists, but obviously the GP is far better placed than most other doctors within the health network of the patient to develop this kind of lifelong bond with them. The friend archetype wants this type of relationship from the beginning. They often forge contact with the doctor in the social plane, so outside of work. The disconnected patient shows no signs of interest in their own health, sadly. They are often depressed and exhibit apathy. And in complete contrast to the friend archetype, are not interested in engaging with the doctor. Some disconnected patients suffer from general social phobias and may also have mental health challenges like autism, but this is by no means the case for the majority. For me, it is quite the triumph to get a disconnected patient to emerge from their social coma. It's like finding a pot of gold at the end of a rainbow. The tester is the patient who only has an intellectual interest in the doctor. They don't really have worrying symptoms, but they come to test the competence of the doctor, with often fabricated or exaggerated symptoms. They are often very intelligent, like the engineer, but often with boredom or deep mistrust at the root of their behavior. Testers are a nightmare for doctors because they rob the doctor of time that could be better spent on patients with real problems. Rarely, testers are actually seriously mentally ill. In the worst case scenario, they have Munchausen syndrome, of which I touch on in this video. My pediatric colleagues have the pleasure of dealing with a Munchausen by proxy parent who brings in a child with different, confusing, and often fictitious injuries and symptoms. The tester is a real challenge, but we remember that they are patients too. The deity worshipper archetype is my least comfortable archetype to deal with because they violate my principle that the doctor is not a god with a capital G who is infallible. To my distress, I often don't enjoy my encounter with this type of patient because I don't come from the generation in which doctors were God with a capital G, and I have a healthy dose of imposter syndrome to boot that prevents me from getting big-headed enough to believe their hype about me. It's quite a challenge for me personally. This patient is usually elderly, and if they are young, they often hail from a different culture to the Western one. This reminds me of a joke actually, this particular archetype. The joke goes thus: what's the difference between God and a surgeon? Answer: God doesn't think he's a surgeon. The heart sink patient. I am not being facetious. This is actually a term used by the medical establishment and is a term used to depict the doctor's failings and not an admonishment of the patient, who is an innocent party here. Every doctor, unfortunately, has their version of the heart sink patient. Remember, this is a reflection on the doctor, not the patient. The heart sink patient represents a reflection in the mirror of the doctor's failure, and no one likes to stare their own failure in the face. It's the patient you can't help because they have challenging symptoms you can't diagnose. And if you do have a diagnosis, it's the patient you can't help because what they have has no cure. Or there is a cure, but you either don't know what it is or you can't access it. It is by definition the patient who literally makes your heart sink whenever you see them. The consultation is rarely satisfying for either party. You come away with the feeling that you just wasted their time, and the feeling is mutual. You want out of the relationship because it weighs heavily on you. Unlike the tester who is there to deliberately wind you up and is a perpetrator, at least that's your perception of things, the heart sink patient is a victim of their own health and desperately needs your help. So you do your best for them, no matter how inadequate you feel. What is the point of categorizing patients into different archetypes? It is certainly not to whine about the archetypes. The point is to understand their basic psychology. You cannot treat an engineer the same way you treat a tester. Knowing how the patient relates to me helps me to deliver a tailored care strategy to them as an individual. The specialist likes to receive the latest research about their illness. No problem. I shall spam their inbox with any studies I find. The friend wants to invite me to their daughter's wedding. I'll buy a hat. The disconnected doesn't want to know their cancer diagnosis. Okay, I'll keep stum. It's about respect for the patient's needs and wishes, within reason. It can be a delicate dance, but no one is looking for a gold medal here.
We got ray gun.
It was an Olympic performance.
Bam. Bam, bam.
Because we are all different, a tailored approach to our medical care is a useful plus in our health journey. I could literally go on and on about all the archetypes I have personally come across, but this video is already quite long. Do you think you fit into any of these archetypes I touch on? Do you wish to share any other archetypes you know of? Do you want to hear of more archetypes from me? By all means, let me know your thoughts. Askadoc.